Hi, everyone. Thanks for joining me today. I'm Scott Nicholson with the Judy Nicholson Kidney Cancer Foundation. And today I'm very excited to have Dr. Anca Zegrean with us. She has studied at the University of Medicine and Pharmacy in Romania. She owns her own practice and she's affiliated with Northwestern Medicine. So she's here today to talk with us about how to take care of your remaining kidney. And she called in some backup. She's got a reinforcement today with Dr. Francesca Mead. She's in her second year of residency at Northwestern Medicine. So thank you, doctors, for joining us today.
Glad to be here. Hello.
All right. I think everyone can see your screen. So whenever you're ready, we're ready to get started.
Perfect. You can hear me well?
Yes, we can.
All right. So I've been in the nephrology practice for over 10 years now. I'm working in Chicagoland area, and I'm glad to be here this afternoon to share some of my sort of thoughts and experiences with everyone on the line. I have a lot of information in the slides. Some may be overwhelming maybe at times. I think the slides will be available for review for later on, and I'm happy to answer questions when the presentation is done. So let's get started. So first of all, it's a hard battle, and I'm glad to have you all here this afternoon. And it takes a village. So I think that would be sort of the biggest message that I would like for all of you to take home, is that the team is behind you, and you'll have to unfortunately spend time with different doctor's appointments and different visits, but it is a complicated disease, and we do need backup from each other's as physicians. So having the right people on your side, it always makes a difference and helps you fight this fight that you're going through. So just some basic sort of remarks. Having had a diagnosis of cancer requires oftentimes frequent blood tests and frequent other imaging tests, not only for monitoring your sort of your cancer stages and response to therapy, but also monitoring certain metabolic indices. And in our case, the purpose of our talk is focusing more on monitoring the kidney function and how the kidneys are handling everything that's being thrown at them. Because, between going through chemotherapy and going through surgeries and anesthesia and a lot of other medications that they have to sort of filter and take care of, it is important that we keep a very close tab on the kidney levels and function at all times. So I think our purpose here is to discuss sort of how the kidneys do after a kidney was removed, or sometimes partial removal of a kidney, which is called a partial nephrectomy. So unfortunately, a large number of patients that go through different degrees of nephrectomies, whether it's a total or partial, will have an acute increase in the serum creatinine. And serum creatinine level is our marker that we use to estimate the kidney function, along with the BUN levels and another number that we monitor on the blood work, which is called the eGFR. I think the most important thing is to understand that the lowercase e in front of the GFR stands for an estimate. So nothing is an absolute measurement. And all we can do is to best estimate based on a very complex equation of what the kidney function really is, and respond accordingly. So by having a kidney removed or part of a kidney removed, you will automatically lose some of your nephrons, some of the kidney cells that are filtering the water and the toxins from our bodies. So naturally, that creatinine level will have a steep rise immediately after surgery. Now, in most cases, the remaining kidney will be able to pick up some of the function by growing, by getting a little bit larger and kind of engaging the reserve, if there is a reserve. So we oftentimes see that creatinine level that may initially be quite high to sort of plateau or even improve slightly after about 6 months, 6 to 12 months after the nephrectomy, after the kidney was removed. So it is very common to see this acute increase, and it is defined as an acute kidney injury. Not that necessarily the remaining kidney is injured, it's just based on sort of the markers that we monitor that creatinine increase sort of falls into the diagnosis of an acute injury. Now, unfortunately, a lot of patients that have a renal cancer may have chronic kidney disease along with it that could sometimes precede the diagnosis of a malignancy. And in some cases, we know the renal cysts can be there, and over time, those can transform into a malignant cyst, and other transformation can occur. And oftentimes, chronic kidney disease and renal cancers go hand in hand. And again, the importance of establishing the real kidney function and sort of the strength of your kidney is important because of making the right choices of medications and treatments moving forward. And most importantly, where my role comes into all this is managing chronic kidney disease and managing some of the associated conditions that sort of derive from having chronic kidney disease, such as high blood pressure, anemia, and electrolyte problems, potassium problems, calcium, and so on. So what are the main causes that can cause an increase in the creatinine level, other than having that kidney removed? So having had prior acute kidney injury for any other reason puts you at risk of developing chronic kidney disease. Certain medications that could be toxic to the kidneys are also contributors to this. Unfortunately, some of the chemotherapy or anti-cancer agents themselves can cause kidney injuries. The mass, the loss of the kidney, obviously, like I said, it causes a direct loss in the filtration function of the kidneys. And then some malignancies can have an association with different degrees of obstruction, meaning different blockages at different parts of the urinary tract that could be related to the cancer or not. Sometimes an enlarged prostate could be causing problems, or other kidney stones or other problems can sort of coexist with cancer diagnosis. And then exposure to radiation can also cause some scarring sometimes. So renal cell cancer can coexist with chronic kidney disease and can be a pre-existing condition. It is one of the risk factors of developing renal cancer. And it is very important for the renal function to be determined as accurately as possible before the surgery would happen, and then very closely monitoring is needed after the surgery. So quite a large number, as studies have shown, of patients that underwent kidney surgeries, various degrees of nephrectomies, have had pre-existing chronic kidney disease, about a third of patients. And this could be related to the risk factors that are pretty common for both of these conditions. Age, being a male, smoking, and other conditions such as being overweight, having diabetes, or hypertension. So just a quick review to give everyone sort of a brief idea of sort of what do we mean by stages of chronic kidney disease. I know a lot of people get nervous when we talk about a stage, especially when having a cancer diagnosis. So stages of CKD have nothing to do with the staging of a tumor or a cancer. Stages of CKD are only sort of based on the filtration fraction of the kidneys. And this slide explains how we split these different stages based on the filtration capacity of the kidney. Normally, I would expect that somebody that has had a kidney removed or a large part of a kidney removed will fall into the category 3A or 3B and below. Below meaning lower function and higher CKD stage. Typically, CKD stage 5 is nearing dialysis or needing a form of renal replacement therapy, typically dialysis or a renal transplant where that is something feasible. The staging is very important as a nephrologist because we have sort of different guidelines and different parameters that we need to monitor and different targets as far as to where the blood pressure needs to be, where the electrolytes need to be, where the anemia and so on, all these other associated conditions. And again, it is important for using or not using certain drugs, certain medications based on this GFR levels, or adjusting the dosages, the frequency of the medications that we prescribe. So again, the main risk factors, a little more in depth. Diabetes is currently the #1 cause of chronic kidney disease in the United States. Cardiovascular disease, hypertension follow, being overweight. Certain infections can sort of predispose to kidney injury over time. A strong family history, certain autoimmune conditions that are inherited, or polycystic kidney disease, or other genetic factors can be contributing to this. Obviously, exposure to any nephrotoxic drugs sometimes could be a remote exposure, sometimes a more recent one. And in this, I would include IV contrast that is very commonly used for CT scans. And unfortunately, in the wrong setting, it can become a nephrotoxic agent. Having a previous kidney injury puts you at risk of developing chronic kidney disease over time. And then malignancy itself, through different mechanisms, can cause chronic kidney disease. So how do we approach, how do we tackle this issue? So first would be identifying the cause if we can. And if it is a reversible cause, such as an obstruction or uncontrolled blood pressure or uncontrolled diabetes, trying to work on reversing and treating those conditions. The next sort of goal would be preventing further damage by making sure all the medications are the right ones for the patient. And most importantly, trying to slow down the progression of the disease. And this is, again, we've had some medications recently that have been shown to help with slowing down the progression. And, controlling the environment sort of does help, and it's something that we try to work on. And then, sort of the bread and butter is treating the complications. So, we avoid worsening of the kidney function, and sort of quality of life is maintained. And, we use different medications to do so. We always have to be mindful of the medications that are prescribed, the dosages, and looking at that GFR and stage of the chronic kidney disease. And lastly, when the kidneys, unfortunately, or the kidney gets to the point where, all the above measures have sort of failed, or they're a bit too late to cause a significant improvement, is preparing for the next step, which would be sort of renal replacement therapy, such as hemodialysis, peritoneal dialysis, or where possible, a renal transplant. So what are some other reversible causes of renal disease? Are decreased sort of fluid in the body, which could be induced by diuretics, could be induced by GI problems, and trying to correct those as soon as possible is essential. Having low blood pressure, again, is something that needs to be addressed. High blood pressure is a big enemy of the kidney, but so is low blood pressure. So it is important that we try to maintain an adequate blood pressure in a good range to ensure that the kidneys get enough perfusion, get enough blood flow, where they would not be harmed further or would not sort of precipitate the chronic kidney disease. Treating any infections if applicable. And then the biggest nemesis, sort of our big enemy, is the non-steroidal anti-inflammatory drugs, which are very commonly used. They're over the counter, and some specialties also like to use this, even from dentists to orthopedic doctors, and they are good pain control medications. But they are not the safest choice for patients that have chronic kidney disease or that have reduced kidney function. And another medication that could potentially cause some kidney injury in the wrong situation are, again, prescribed as a renal protective agent, the ACE inhibitor ARB type of group, which would include commonly used blood pressure medications such as losartan, lisinopril, which a lot of people may be familiar with, and they are great medications in the right setting. So again, they have to be very carefully monitored. So the non-steroidal anti-inflammatory drugs, they're one of the most common sort of inducers of acute and chronic kidney disease, because they're widely available, because a lot of people use them early on in life without necessarily being monitored, and unfortunately these medications can cause an acute change by inflammation of the kidneys, but they can also cause a slow sort of chronic injury, and that may not be evident for a long period of time. So for our purposes, the recommendation is that they should be avoided at all costs when the kidney function is less than 30 filtration rate, and they should be limited to seldom use, preferably no use, when the filtration fraction is less than 60. So this includes patients with stage 3A, 3B, and below, as far as the CKD staging goes. And more importantly, when they are used in association with other medications, such as the ones I had mentioned, lisinopril, losartan, or diuretics, can sort of precipitate the renal sort of harming effects. IV contrast, I had mentioned this a little bit earlier. Unfortunately, this is needed, especially when monitoring response to therapy. Sort of surveillance scans are being done in cancer patients. Most cases, this will be needed. Fortunately, the recent data, the recent contrasts are a little less harmful to the kidneys. That being said, we don't have a lot of tools to use as far as prevention of the contrast, other than making sure the patients are well hydrated. So the recommendation is to start with oral hydration the 24 hours before the test is being done, if it is a scheduled procedure, or I'm sorry, a scheduled investigation and not something that is emergent. And lastly, hydration with IV fluids should be started about an hour before the procedure, very important, and continued for about 3 to 6 hours afterwards. Also, there are certain medications that should be avoided at all costs when a contrast study is scheduled or planned for. And lastly, the kidney function should be rechecked about 2 to 3 days after the contrast exposure to monitor for any chance or any signs of kidney injury that occurred due to the contrast administration. So moving forward to sort of what do we do in general with slowing the CKD progression, because unfortunately chronic kidney disease, the name speaks for itself, it is a chronic condition, and it does tend to have a progression over time. Even in best case scenarios, even in best maintained patients with perfect blood pressure control and perfect sort of environment, unfortunately there will be a degree of loss of GFR over time with aging and sort of with other environmental situations that we cannot sort of entirely prevent. So one important thing as far as diet is restricting the protein intake and trying not to expose the body to any heavy protein supplements, heavy protein diet that would really put a lot more strain on the kidney. Speaks for itself, smoking cessation, I think, should be, kind of the first and foremost intervention that anyone in this situation should have. And then treatment of other metabolic conditions such as acidosis and bone and mineral disease, where sort of additional strain on the kidney may be felt if their associated conditions are not addressed. Controlling the blood sugar in a diabetic patient is essential. Positive findings are these new recent studies with the class of drugs called SGLT2, which are you may have seen, I'm sure commercials are all over the TV all the time. I feel like for Farxiga or Jardiance are one of this type of medications. And these have shown some promising results in sort of the 2-3 years report that we have as far as slowing down the progression of chronic kidney disease, reducing the amount of protein in the urine, and overall improving diabetes control. So these are sort of the newest treatments that we have. Blood pressure control is essential. Target blood pressure is usually about 130/80, with some small variations depending on other comorbid conditions such as proteinuria and diabetes. In some situations, we aim for a little bit lower blood pressure readings. Reducing the salt intake as much as possible, avoiding any salty foods is very important. Our regular, American diet has probably 2 times more sodium than what it would be indicated by for a patient with chronic kidney disease and hypertension, which should be maximum 2,000 milligrams. So it's about 2 grams of sodium per day. It's hard to achieve that sometimes. It takes a lot of careful planning, reading labels, and kind of knowing what fits in and what doesn't fit. Using the ACE and ARBs, which is the medications I had mentioned already, similar to the diabetic drugs that I mentioned as SGLT2 class. They have also shown to help sort of slow down the progression of chronic kidney disease and reduce proteinuria while achieving better blood pressure control. Diuretics are generally used in most patients with chronic kidney disease, especially later stages where fluids management by the kidney is becoming a bit of a problem. So most patients with chronic kidney disease stages 4 or higher will require a formulation of a diuretic to be added to their blood pressure regimen to be able to achieve adequate blood pressure control. Target glucose is an A1C of about 7, unless there are any other coexisting factors. It is an important measure of reducing the progression of kidney disease by reducing the protein in the urine, and with that having a positive effect. And then again, the sort of the bigger helps that have arrived recently is this new class of drugs that I had talked about already. Okay, so other sort of coexisting conditions that derive from having chronic kidney disease include mineral and bone disease, secondary hyperparathyroidism that translates into an elevated parathyroid hormone level, PTH, which you may have noticed appears on your blood work panels when you see one of your physicians, your nephrologist or your primary care doctors. Vitamin D deficiency is very common because the loss of renal mass leads to decreased activation of vitamin D in the kidneys. And as a result, the active vitamin D levels will be reduced in the body, and therefore hypocalcemia and hyperphosphatemia will occur. These levels should be monitored every 6 months at least, or once a year, depending on the GFR level. And this again falls more on the plate of your nephrologist to kind of based on your CKD stage to monitor at different intervals and intervene accordingly by prescribing vitamin D formulations and phosphate binders or other supplements as indicated. So just sort of a little overview of how complex the kidneys are. Most people think about the kidney just, producing the urine, getting rid of the water from the body. However, the kidney is the smartest organ in the body, and I'm a little biased, but I still think so. It does play a role into regulating a lot of different metabolic and other functions of the body, such as anemia, which a lot of people, have a hard time sort of putting them together. But again, erythropoietin is the hormone in our bodies that is naturally produced and regulates the production of red blood cells. When you lose a kidney or when the kidneys are not functioning well, the level of erythropoietin is decreased. So therefore, most kidney patients, most chronic kidney disease patients will have a different degree of anemia. The bone mineral disease that I've described already have to do with the activation of vitamin D in the kidney, and a lot of these patients will need some support with medications. Lastly, having chronic kidney disease can precipitate the process of atherosclerosis and kind of put patients at risk of cardiovascular complications and cardiovascular diseases that can lead to other complications and other problems. I think I would sort of conclude here. And again, I think my biggest message is, have a team, have good conversations with your doctors, with your nephrologists, and it does take a village, but it can be done, and you're not alone, and you have our support.
Thank you so much, Doctor. This was such a great talk, and we did have a question, but it got answered during the conversation later on. But
Okay.
Scott Schaefer has a question here. Should intense cardiovascular activity be avoided in patients with one kidney?
The short answer is no. The long answer is it depends. I mean, what do we mean by, intense cardiovascular? It depends on each person sort of.
My definition of intense
status.
is going to be different than
Yes.
theirs, I'm sure.
So if you as a baseline have been running marathons and have been, I don't know, doing some extreme races and things like that, having just one kidney should not stop that. There may be a sort of re-accommodation period, obviously, with monitoring and making sure that everything is functioning the way it should be. But I do have to say, there's about 10% of people that are born with one kidney, and they live a normal life, and sometimes they don't even know that they had one kidney unless they have some other additional testing. And then, another sort of positive here is that we have live kidney donors. So we have a lot of people that are healthy and they choose to donate a kidney to a relative or sometimes to a person they don't know. But living with one kidney, if that kidney is healthy enough, should not preclude you from doing any type of physical activity or anything else that your functional status may allow.
Thank you, Doctor. Sherry had a question. Do you consider one kidney as having kidney disease? And do you suggest IV hydration 1 hour prior and 3 hours after when given Opdivo infusion?
So losing one kidney automatically makes you lose half of your kidney function. If that remaining kidney is completely healthy and you're otherwise a healthy person, then likelihood is that, like I mentioned, that kidney can pick up some of the function. And a lot of people have consider normal GFR or normal kidney function with just having one kidney. The problem is when there are associated conditions or other pre-existing conditions where that remaining kidney may not be functioning at its full capacity. But in general, it is a good idea for somebody that had a kidney removed because of a cancer to be closely monitored for sort of changes in kidney function and creatinine levels. So sometimes that eGFR may be misleading. So it is important to look at trends and to see where you were before the kidney was removed, where was the GFR and the creatinine afterwards. because sometimes we may have a creatinine that goes from 0.7 to 1.1, and that doesn't necessarily get flagged by the blood work as elevated creatinine, or does not, get triggered, doesn't automatically trigger a CKD sort of diagnosis. But it is a significant increase, and for a nephrologist, that is something that they should and they would monitor, because it is an increase that could be significant. And as far as hydration before Optivo, that's usually a decision from the oncology team. I believe they have their own protocols in place. I don't know that it is directly indicated, but it's a case by case. I think depending on patient, depending on sort of other conditions and things.
Thank you. Paige had a question. Who specifically should be on your medical team?
Urologist, obviously. You need a good urologist, depending on the stage of cancer and the surveillance and the type of your pathology and all that. An oncologist is oftentimes involved. And then lastly, nephrologist, and you should have a good primary care doctor to kind of oversee the care and coordinate with all the subspecialties.
And Sherry with a follow-up question. Should we automatically request bone scans?
No, those would not be needed unless indicated, no.
Understood. Well, I think that's about it for our questions today, Doctor. But if anyone did happen to come up with other questions, would it be okay if we reach out to you?
Sure, absolutely, yeah.
Oh, Scott Schaefer's we got time for one more. Scott asks, how much water should we be drinking?
So a good amount, unless there are other like congestive heart failure or other conditions that are associated, the recommended amount would be about 60 to 70 ounces a day. And water would be the best sort of hydration drink for kidney patients. We recommend avoiding sodas, juices, and all these sports drinks, electrolyte drinks should be used with extreme caution and moderation.
Sherry asks, related to the previous one, how much alcohol is too much? And we're getting into questions that are.
Oh, well, that's gonna be a different topic, I think. There is, as far as the kidneys go, I think the recipe for success is moderation. And this applies to food, this applies to, drinking and exercise and everything that our lifestyle can offer and we can control through our day-to-day sort of habits. So I like to call the renal diet the kidney smart diet. That means be smart about what you eat and drink.
So maybe take less than before. Err on the side of caution, Sherry. Doctor, thank you so much for spending your time with us today. And I know that you answered a lot of great questions, and our chat, lots of people are thanking you for your time today. So if you missed any part of this talk, yes, sorry. If you missed any part of this talk, anyone, we'll be posting it on our website this coming Monday. So please look for it there. That's it for today. Thank you, Dr. Zegrean.
Have a good afternoon. Bye-bye.
Thank you. Goodbye.